below 90 for more than 20% of your total sleep time. So there's more qualifying criteria when it comes to the severe versus the moderate versus the mild. So be sure that you can look at this information and you have all of this when it comes to differentiating between mild, moderate, and severe OSA. When we look at central sleep apnea, there are two different types of central sleep apnea. We have primary central sleep apnea and we have secondary central sleep apnea. And the way that we differentiate between obstructive sleep apnea and central sleep apnea is when they are going through the polysomnography or the sleep study, they have electrodes all over their head that is monitoring and recording information, brain waves. There's upwards of 20 to 30 electrodes that are stuck to the patient's skull or their scalp so that they can measure brain waves. The other thing is you have a nasal cannula that can deliver oxygen and monitor end-tidal CO2. So we've got capnography going on. We've got a belt that goes across the chest and a belt that goes across the abdomen and a pulse ox. So you got a number of different cords that these patients are attached to that lead the diagnostician or the respiratory therapist to recognize or identify and differentiate between central sleep apnea, obstructive sleep apnea, or even a mixed. So when we talk about central sleep apnea, this is essentially the brain saying, we're not going to breathe. We're not breathing right now. When we talk about obstructive sleep apnea, there's some sort of anatomical structure that is blocking airflow. So to differentiate obstructive versus central, with obstructive, you do have chest and abdominal movement. With central, you do not. Neither one of them get airflow into the alveoli or into the respiratory zone, but one has chest movement and the other one does not. So breaking down central sleep apnea, there are two different subcategories where they're primary and secondary. When we look at primary is associated with idiopathic or of an unknown origin central sleep apnea. When we look at secondary central sleep apnea, we're talking about patients that have Cheyne-Stokes breathing. And remember, Cheyne-Stokes breathing is associated with CHF. When we have patients that have or may have CHF, those patients can end up with Cheyne-Stokes breathing. Remember, that's a period of apnea, a crescendo, and a decrescendo of a breathing pattern. They can have encephalitis or brainstem neoplasm. There can be a brainstem infarction. They can have spinal surgery, hypothyroidism, drug and substance abuse, high altitude periodic breathing, reducing their PaO2, bringing on irregular breathing patterns. So there's a number of different things that are associated with the secondary central sleep apnea, and only one thing that's associated with primary. So when we look at central sleep apnea, like I said, there is the primary and there's the secondary. When we look at the primary, this is typically associated with hyperventilation. When we look at secondary, this is associated with hypoventilation. So you have hyperventilation that's associated with CHF or high altitudes. You have cycles of apnea, hypopnea, or even hypernia. You have ventilatory overshoot, you have hypocapnia, you have central apneas, hypercapnia, and reoccurring hypernia. So a number of different looks when it comes to that primary central sleep apnea. And typically, these patients start with a normal baseline CO2. When we move into the secondary central sleep apnea, these patients do not have a normal baseline CO2. So who are our patients that typically do not have a normal PaCO2? Well, we talked about TB, those patients having a irregular CaO2, but our COPD patients, those are ones that really are well known for their change in their blood gases. Other ones that you might see are neuromuscular patients. like Guillain-Barré or myasthenia gravis that will impair gas exchange. When we look at these patients, they typically have cycles of normal ventilation, hypoventilation, and apnea. So again, the type 2 or the secondary CSA is way more related with hypoventilation, whereas the type 1 or the primary central sleep apnea is associated with hyperventilation. These patients here, they have no desire to breathe. They're trying not to breathe. So when we look at CNS decrease, this could come from drugs and substances like alcohol or opiates or barbiturates, benzos, tranquilizers. All of these different medications can lead to these patients having a decreased central nervous system, which will decrease their desire to breathe. So we have two different types of central sleep apnea, and this kind of breaks it down a little bit. When we look at the diagnosis of central sleep apnea, this is looking at any majority of the events that we talked about during the polysomnography. Most of these are central apneas or they are hypopneas. One of the two. That will kind of lead us down the path of recognizing. So how do I differentiate between central sleep apnea and obstructive? Well, there's an absence of flow. We know that there's an absence of flow with obstructive and central. But when we look at the thoracic abdominal movement, there is no thoraabdominal movement. So you don't get any movement of the chest or the abdomen trying to bring volume in, creating basically no ventilation that's taking place at all. With obstructive, you do have the movement of the chest and the abdomen. There's simply something that is blocking or obstructing the airflow from getting into the lungs. When it comes to central sleep apnea, we have to rule out any cardiac disease, lesions in the cerebral cortex, or any impairments to the brainstem. So when we look at these sleep apnea patients, they, during sleep, no longer have the wakefulness and the stimuli to breathe. And as a result, you end up with alveolar hyperventilation and central apnea that occur. And the patient's breathing is restored during arousals from sleep, but again, decreases when sleep resumes. So this results in periods of normal ventilation, hypoventilation, and apnea. The choice of therapy is based on whether the patient's central apnea is hyperventilation or hypoventilation in nature. But when we have these patients that have central sleep apnea, we need to rule out any cardiac disease or lesions in the cerebral cortex and or abnormalities in the brainstem. And when we look at these guys, if there is cardiac disease or cerebral disorders, then that is what needs to be treated and not necessarily the central sleep apnea. We have to make sure that we are focusing on treating the cause and not only the symptoms. But a lot of times we have patients that have AFib, and AFib is associated with the central sleep apnea. So the next thing that we really need to talk about is this kind of overlap between central sleep apnea and obstructive sleep apnea called mixed sleep apnea. And this is when you get a combination of central sleep apnea and obstructive sleep apnea. And what typically happens is patients will start with central sleep apnea, and then we will add in obstructive sleep apnea, and it will create or cause this mixed sleep apnea. And the way that we're going to really treat this form of apnea is we're going to spend way more time treating it like it's an obstructive sleep apnea than it is central. So let's talk about that just a little bit more. So when we look at this, remember we talked about the different airflow patterns. So with obstructive sleep apnea, you have no airflow pattern. With central sleep apnea, you have no airflow pattern. With mixed apnea, you have no airflow pattern. So how do we differentiate between these two or these three? Really what we're doing is we're looking at how much pressure is being produced by the thoracic cavity. If I were to look at here, right here in the obstructive apnea, we get a change in the esophageal pressure. Well, if I'm getting a change in my esophageal pressure, that means that my thoracic chest is moving, creating a negative pressure in the esophagus. So I get this movement of negative pressure, but there's no airflow movement. And anytime that we've talked about the movement of the diaphragm or the movement of the thoracic cavity, there's always been airflow that's associated with that. Well, this doesn't happen when you have an obstruction. So you have a negative pressure that's created, and then you have no airflow, which is from the obstruction. Now, whenever I go to the esophageal pressure over here in central sleep apnea, this is your brain taking a rest or being confused by another condition that you're oxygenated enough that you don't necessarily have to breathe during that period of time. So this is your thoracic cavity not changing, not moving at all, thus giving us no change in airflow movement either. But when we look over here at the mixed apnea, you have this period of time where there's no thoracic movement, and then you get these tugs of your thoracic chest trying to create airflow. Once it does, it pulls enough pressure here. This is a negative 40 to negative 80 centimeters of water of pressure. Remember that pressure that's created in the thoracic chest during quiet breathing is 3 to 5 centimeters of water. This is like 20 times that much pressure. That is a lot of pressure that your thoracic cavity is trying to create just to get any airflow. So imagine what your body is doing, what your brain is having to go through while you're sleeping. So it makes sense that your patient, or even you if you're exhibiting these symptoms, it makes sense that your patient doesn't feel rested. They're fatigued throughout the day. They have restlessness, or they have forgetfulness. All of these things make sense when your brain's not getting the chance to reset and not getting a chance to slow down and restart itself. And then the last graphic that we have here is for oxygen saturations. When we look at the saturations for obstructive sleep apnea, these sats will drop further than the central sleep apnea, and then your mixed apneas are going to be somewhere in between. Then we have what's called sleep-related hypoventilation and hypoxemia syndrome, or SRHHS. SRHHS for short. And what we're talking about here is obesity hypoventilation syndrome, or Pigwiddian syndrome. So basically these patients and these folks have so much adipose and they have so much weight on top of their chest that it creates a restriction and an opposition to flow, because the body is having to move so much just to get any airflow. It creates this obesity hypoventilation syndrome, or what we call Pigwiddian syndrome. So when we look at this, there's a broad range of sleep disorders that are associated with SRHHS. And the one that we've talked about the most, and the one that we're probably most common with, is the Pigwiddian syndrome. But this can also happen, and it can coexist with COPD. When we have this overlap with COPD, we call it an overlap syndrome. So you get a number of different disorders that are associated with SRHHS. Other conditions are typically pretty rare, but you can have a congenital central hypoventilation syndrome, or you can have neuromuscular disorders, or even chest wall disorders. All of these are characteristics of abnormal gas exchange that worsens or maybe even present itself when the patient's asleep or even sedated. So we'll see these types of things and these abnormalities usually caused by hypoventilation in hypercapnia way more than we see it with hypoxemia. And other disorders that it could be associated with, like chronic bronchitis, emphysema, which we kind of covered that with the COPD. These aren't considered standalone conditions. These are specifically sleep-related disorders. And when you have COPD, or specifically emphysema and chronic bronchitis, These are known to have a cause in hypoventilation that yield that hypercapnia and hypoxemia during sleep. In these cases, the diagnosis of SRHHS should be considered. Unfortunately, the diagnosis of overlap is typically overlooked. So, in the critically ill or those that are hospitalized, this is something that we need to make sure that we're doing a good job of recognize these things when we see them in the hospital, so that we can make recommendations for the docs, so that we can make recommendations to the providers to get these patients on